Good evening. I'm Kelly Gear-Ripken, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, thank you for joining this evening for our monthly webcast series, Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. Tonight, we are pleased to be joined by three Johns Hopkins experts who are part of the Johns Hopkins Post-Acute COVID Team Program at Johns Hopkins. Symptoms of mild or moderate COVID-19 last about 2 weeks for most people, but in some others, long-term effects of COVID-19 can linger for months. The Johns Hopkins Post-Acute COVID-19 Team Program is a collaboration between the Division of Pulmonary and Critical Care Medicine and the Department of Physical Medicine and Rehabilitation at Johns Hopkins, providing standardized care to address the unique needs of COVID-19 survivors. Tonight, we are joined by three members of this team, including pulmonologist Dr. Ann Parker, neuromuscular physician Dr. Tae Chung, and rehabilitation physician Dr. Alba Azola. So please use the Q&A on your screen to pose your questions to the doctors who will respond during the last 30 minutes of tonight's conversation. Our webcast this evening will conclude at 8 p.m. And I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance, and you can visit their website for additional lectures and courses throughout the year. And now I'm pleased to welcome Dr. Parker.
Great, thank you so much for that kind introduction. And I'm so pleased to be here this evening to talk with you a little bit about our experiences with patients who have long COVID or post-COVID condition. So as introduced, I am a pulmonologist and intensivist at Johns Hopkins and the Division of Pulmonary and Critical Care Medicine. And I am also co-founder and co-director of the Johns Hopkins Post-Acute COVID Team, or JH-PACT, as you'll hear us refer to it. And I'm here tonight with my dear friend and colleague, Dr. Alba Azola, who is our co-director leading the rehabilitation side of our program. So I'd like to start by providing a review of the World Health Organization, or WHO, working case definition for post-COVID condition. And so what this involves is having a probable or confirmed diagnosis of SARS-CoV-2 infection with symptoms that are occurring at about 3 months after that initial infection. And these symptoms generally last for at least 2 months, but we know they can last much longer than that. These symptoms can include things like breathlessness, fatigue, brain fog, persistent loss of taste and smell. These are things that you've heard of reported before. These symptoms generally can relapse and remit, and we see that often in our patient population. So patients describe having good days and bad days. Importantly, these symptoms can't be attributed to another diagnosis. And very importantly, they generally have to have some functional impairment associated with them. And you'll hear more about that from Dr. Azola. But basically, these symptoms have to be making it challenging for patients to do the things that they need and want to be able to do to get back to their lifestyle. In terms of prevalence or incidence, how many people are experiencing long COVID or post-COVID condition, it can be really challenging to pinpoint these numbers. However, most recent estimates are that about 10% of people with COVID-19 illness can have persistent symptoms that last beyond that initial phase of infection. We do know that more severe initial COVID-19 illness is a risk factor for having persistent symptoms. However, we know that patients who have mild illness at the onset can also go on to have persistent symptoms. And I'd like to talk a little bit about how our program, JH-PACT, came to be. So if we kind of go back to the spring of 2020, and remember that at that point in time, we were witnessing a surge in critically ill patients appearing in our intensive care units with COVID-19. And so we immediately in March of 2020 started thinking about how can we support these patients beyond their acute phase of illness and into the outpatient setting as they continue to recover. And so we immediately started as a partnership between pulmonary and critical care medicine and physical medicine and rehabilitation. And our staff were stretched quite thin at that point. And this was really a grassroots effort with numerous individuals from multiple divisions and departments pulling together to provide this additional care for our patients as they transition to the outpatient setting. And we knew from the beginning that we would be supporting our critically ill patients because we were seeing such a large number presenting to the intensive care unit. And my research background for the past decade or so has been in understanding and improving care for critically ill patients. And so we know from decades of research that individuals who have been in the intensive care unit for any reason and have had respiratory failure are at risk for having impairments in mental health, things like anxiety, depression, PTSD symptoms related to their experience in the ICU, cognitive impairment, and impairment in physical function. And so we knew based on that previous literature that predated COVID that we could expect that our critically ill patients would at least be at risk for these impairments after their critical illness. And so in the spring of 2020, when we established our program, we did so with what we call a post-intensive care syndrome or PICS framework in mind. And you heard me sort of cite the numerous domains of impairment that critically ill patients can encounter. And so that is why we initially established as a multidisciplinary program as a partnership between physical medicine and pulmonary medicine. However, we were humble from the very beginning to recognize that our patients who had mild initial illness might also have challenges in their recovery. And in the spring of 2020, the term long COVID was really just starting to come to be as a patient-derived term that was appearing on social media. However, we, from the very beginning, have included patients in our program that span the spectrum of initial severity of illness, from very mild illness, not requiring hospitalization, to our sickest patients who were in the ICU with substantial life support. When we initially started, we were entirely telemedicine because of infection prevention control measures at that point in time. And so our program stood up entirely telemedicine. And since then, within several months of starting, once those infection prevention control measures were lifted, we were able to start seeing patients in person as well. And so now our program has expanded to include other providers, and we have a hybrid model where we see patients in person as well as via telemedicine, depending on a patient's symptoms, their circumstances, really trying to meet patients where they are with a modality that best suits their needs and desires. From a pulmonary standpoint, we tend to see symptoms like breathlessness and cough. And these are complex multifactorial symptoms. So between patients, breathlessness might have very different causes. Even within a patient, we might be able to identify several factors that are contributing to their breathlessness. And we can talk more about that in a bit. Our evaluation from a pulmonary standpoint, like all good medicine, starts with a careful history and physical, really listening to our patients, understanding where their limitations are, understanding what triggers their symptoms, what might alleviate them. And then from there, on a case-by-case basis, we decide which patients might most benefit from things like pulmonary function testing or lung function testing, further chest imaging, or laboratory examinations. There are a lot of questions to explore from a research perspective. I think we have more questions than answers at this point still. It's hard to believe, but that is the case. And when we think about long-term impairments from any disease or illness, we're really talking about months to years after that illness occurs. So while we're 2 years into the pandemic, it isn't surprising, I think, that we're still really scratching the surface in terms of understanding long-term consequences. Science is moving quicker than it really ever has, but this is still a challenging aspect. So understanding things like mechanisms, risk factors, who's at risk, why, for how long, understanding potential treatment options for our patients. These are all questions that we're working to answer. And with the support of the Johns Hopkins School of Medicine, we've been able to establish a biorepository and registry for our program so that we can begin to answer some of those questions. We also contribute in numerous ways to other studies, including an ongoing clinical trial to evaluate the effectiveness of a medication to potentially address lung scar after severe COVID-19 pneumonia. So I will stop there, and I am so pleased to hand over the microphone to Dr. Alba Azola, my colleague who's an assistant professor in the Department of Physical Medicine and Rehabilitation, and my co-pilot and co-director of the JH PACT program.
Thank you so much. And yeah, so I wanted to kind of dig a little deeper in terms of what we know so far. And there's more questions than answers, but there are some theories emerging regarding the pathophysiology. So there's been evidence regarding remnant viral particles or viral reservoirs in the body that could be contributing to the ongoing presentation of symptoms. There's other studies that have shown that some of the symptoms may be explained by autoimmune phenomenon. And some of it may be also an abnormal inflammatory response that is persistently activated. So we don't have clarity of specific of what contributes to what, but those three are the theories that are being worked on, and they're finding some supporting evidence. In terms of the risk factors for patients that were not hospitalized, we know that female sex is a factor, ethnic minority, smoking, obesity, along with younger age. So those are for the non-hospitalized patients that had mild symptoms or asymptomatic SARS-CoV-2 infection. For the patients that were hospitalized, we know that pre-existing comorbidities, diabetes, high viral loads during their initial infection are the risk factors. I also wanted to mention that studies have revealed that COVID-19 can increase the risk of cardiovascular symptoms. So, and also cardiovascular events in general. So higher risk for strokes, arrhythmias, myocardial infarctions, thrombotic events. All those risks are amplified after COVID, and the severity of those risks, or the risk increase with the increased severity of the acute illness. So those patients that were hospitalized are at a higher risk. But even in patients that were completely asymptomatic and had mild initial illness, those two have been found to have increased risk of cardiovascular events. I also wanted to point out that we have identified that there's an increased risk, or by we, I mean, a group from the Veteran Administration led by Dr. Al Ali. He has put together the big data from the VA and has shown that increased risk for lingering symptoms after COVID-19 with reinfections. So after 1, 2, or 3 reinfections, the risk of persistent symptoms increases. And I also wanted to highlight what we know so far about the effect of vaccination in long COVID. There's multiple studies looking at this. In general, the takeaway is that the vaccine is protective against lingering symptoms past 28 days. It's protective in varying degrees depending on the study and the variants that are predominant, but there's certainly a protective effect on the development of long COVID. I wanted to talk also about what this clinical presentation looks like, right? What are these patients reporting? And I, as a physiatrist, concentrate on the function aspect of the patient. So we assess how the symptoms are interfering with their day-to-day lives. And many of our patients report significant symptoms interfering with life, typically fatigue. And this is not just being tired. This is severe exhaustion. It's characterized by basically feeling like their battery has been wiped out. They will say things like, you know, if I go to the store to go shopping, my whole body feels like it's lead. I can't get out of bed. Sometimes these symptoms will present even 24 or 48 hours after they've actually done a physical activity that goes beyond their envelope, or they overdid it, right? So that's one of the clinical presentations we see. Other patients present with fatigue, but not necessarily have this exaggerated response to activity. And that's more of a typical post-viral fatigue presentation, where they just don't have the ability to sustain activity the way that they did before, and it takes time to rehabilitate. Also, there can be a role for deconditioning in some of these patients, especially we see a lot of patients that, because of the pandemic, had limited access to going to the gym or decreased their daily activities because of lockdown. And those patients, you know, we can see an effect on their abilities to reincorporate to lives because of the deconditioning. We also see patients with post-ICU syndrome, like Dr. Parker described. We see patients with new onset fibromyalgia or exacerbation of already existing fibromyalgia. We also see other patients that present with an exaggerated allergic response. So even things that they did not or were not allergic to now cause an exaggeration in the mast cell activation, or that allergic response that's normal, it just becomes exaggerated. That can present with typical allergic symptoms, itching, hives, swelling, sometimes swellings of the lips, or even anaphylactic reactions in those most severe presentations. And in those patients, they can also have GI symptoms, diarrhea, severe abdominal pain, and it's very multisystemic. So long COVID is not one thing, right? Long COVID can present in all of these different clinical presentations, and we're, over the past 2.5 years, we were able to kind of, with our observations, start stratifying the patients into different subgroups and implement therapies that help them regain function and help them get back into their lives. I wanted to highlight also the importance of this on the workforce. We have many patients that are unable to reintegrate to the workforce after having COVID, and many of them can come back to work with accommodations. The American Disability Act has recognized long COVID as a disabling condition, and we work as physiatrists, we work with these patients to obtain proper accommodations at work so that they can function within the context of their symptoms and their impairments. There's one more type of patient that I haven't covered, which is the patients with autonomic dysfunction. And I'm going to hand off to Dr. Tae Chung, who is our autonomic dysfunction specialist, to share a little bit more about his experience managing this particular presentation of long COVID.
Thanks for the introduction, Dr. Zola. My name is Tae Chung. I also belong to physical medicine rehab department. I'm a physiatrist. But at the same time, I did my neuromuscular fellowship. I focused on a lot of nerve and muscle diseases. And even before COVID, I've been running this clinic called POTS clinic. It's not cannabis, it's a postural orthostatic tachycardia syndrome, one of the more, probably more common forms of autonomic nerve dysfunction. I got involved in a PECT clinic team and post-COVID syndrome force because it appears that increasing number of patients who have post-COVID syndrome, they seems to have autonomic nerve dysfunction and clinical manifestation of POTS. So I already had a POTS clinic and a team, so I kind of came in and started working with Dr. Parker and Dr. Zola, which have been really working well. I enjoy really working with them. Now, I just want to clarify that PASC or post-COVID syndrome at this point is not a one single disease. It's a clinical syndrome. Okay? And just because there's a name for that, that doesn't mean that doctors know what we are dealing with. Sometimes we label something because we know there's a serious problem. As Dr. Parker mentioned, we don't know the underlying pathology of all these conditions at this point. We are doing a lot of researches to figure out. And also at the same time, this is a clinical syndrome. So it's not a one single disease. There are many different things that presents as post-COVID syndrome, but we know that under post-COVID syndrome or PASC, there are a few different things, and post-ICU syndrome is one of them that Dr. Parker mentioned. Other things come under post-COVID syndrome, but we recognize a lot of people having autonomic nerve dysfunction and or POTS, postural orthostatic tachycardia syndrome. And POTS, I kind of use this term little bit liberally. They may or may not meet that POTS diagnostic criteria, but if there's any evidence for autonomic nerve dysfunction, I gave a clinical diagnosis of POTS for post-COVID syndrome. Now then, what is POTS? What is dysautonomia? Now, autonomic nervous system is basically a nervous system that controls, that you cannot control from your consciousness, such as your pupil size or GI motilities. And part of the function is it controls your blood flow. And we know that a lot of people with post-COVID syndrome PASC, there's evidence that they cannot control blood flow very well. They cannot handle it because they're autonomic nerve dysfunction. And as a result, they can have a brain fog or inattention because their blood flow is not going to their brain. They have a terrible exercise intolerance where when they cannot increase or decrease blood flow to the muscle whenever they are doing exercise or resting. Oftentimes they have standing intolerance, or when they're standing up or sit up, blood is a water, it doesn't go up by itself. So our nervous system has to shift their blood volume up and down, and that's really not happening in these patients. So this brain fog, exercise intolerance, fatigue, intolerance to standing are typical signs of POTS or dysautonomia that I've been dealing with actually even before post-COVID happened. Also, at the same time, they may develop a lot of GI problems such as nausea, vomiting, loss of appetite, or chronic constipation that can be alternating with diarrhea, and chronic insomnia are also typical symptoms of POTS because they have too much adrenaline that's kind of dumping into their system. It appears that there's some autonomic nerve that's regulating their blood volume is impaired in those patients, in the subset of post-COVID patients. And I think recognizing autonomic dysfunction in this population is important because there are certain treatments that's available for them. It's not a cure at this point. We don't have any a cure to really stop all these symptoms from happening, but there are quite a few interventions available. Basically, we call this volume expansion. we try to hydrate them very aggressively so that they don't have a lot of blood flow problems. And to do that, we have to drink a lot of water, salt diet, and there are known medications that can assist with volume expansion. And as Dr. Zola mentioned, physical therapy is one of the critical things. It can take a lot of time, and because of exercise intolerance, a lot of patients cannot tolerate exercise or physical activity well. So I recommend patients to work with some specialized therapists who are very familiar with POTS dysautonomia or post-COVID syndromes. So, so recognizing those conditions, I think is important. There are certain simple tests, and PEC clinic team, they're doing a great job in screening out patients who may have dysautonomia. They do check blood pressures and heart rates on different positions and ask certain questions that maybe suggest having autonomic dysfunction. So, so I work with PEC team, like as a site, to whenever they recognize autonomic dysfunction or POTS, then I see them and work with our team, who's consistent of physical therapists and nurse practitioners. Now, what is POTS? What causes POTS? Again, we don't have great answer for that, just like in post-COVID syndrome. I am personally interested in autoimmune etiology for POTS. So I think good number of patients develop POTS as a part of autoimmune reactions. Basically, their immune system's confused, and when they fight against virus, they develop a lot of autoantibody, which is kind of a weapon against the virus. Part of them may recognize our own body tissue as an enemy, and then it inflames their nervous tissues and develop either POTS or dysautonomia. Again, post-COVID syndrome is a clinical syndrome. There may be some other patient who get it from remaining virus particles or blood clots, other things too. But I'm more focused on dysautonomia, potentially as a presenting as autoimmune autonomic dysfunction. And as a part of clinical trial, clinical research, we're also starting some clinical trial on new immune drugs for these people too. It's coming up pretty soon, and we'll make an announcement in our website as well. But not only that, Dr. Parker-Zola, we have a lot of different research going on to really try to get to the bottom of what's causing this. So more importantly, what is the best treatment options to help patients with post-COVID syndrome. So I finished a little earlier than time that I allotted, but I probably take time for question and answer.
Great, thank you for all three doctors. This is wonderful. Before we get started, big question. Can we prevent long COVID?
I'm happy to chime in. So, I think that whether we can reduce the risk of long COVID for some individuals remains yet to be seen. I do want to emphasize the importance of vaccination. If you don't get COVID in the first place, if you, by way of vaccination, or if your vaccination means that you have less severe initial illness, all of those things can certainly mean that you are less likely to have persistent symptoms, or that if you do have symptoms, that perhaps they would be less severe and shorter in duration. So we know from studies looking at any potential association between vaccination and persistent symptoms, the larger studies that have been conducted as of late demonstrate that even beyond preventing infection, reducing the risk of infection, folks who are vaccinated are less likely to have persistent symptoms, and generally their symptoms last for a shorter period of time.
Yeah, the other part that's important is the reinfection as well. And I just wanted to highlight that when the numbers in our community increase and you're exposed in situations for example, restaurants or indoor gatherings. It's really important to remember that if the prevalence of the virus is high at that time, it's important to continue implementing social distancing, masking, to protect yourself from reinfection as well, not only depend on the vaccine.
Just to add a little bit, I kind of echo what Dr. Zola already mentioned, because from my perspective, if I see some autoimmune kind of post-COVID syndrome, I mean, there's actually really nothing you can do to prevent autoimmune disease. It's kind of random chance. So the best thing that we can do is to really not getting COVID. And we know the answer. The vaccination is really the only way that we know to prevent getting COVID infection. So at this point, I would say vaccination.
Dr. Chung, are you saying then if you, when you're talking about autoimmune, that are you saying that COVID increases your chances of any autoimmune disease, or it gives you an autoimmune disease? Could you clarify that?
That's actually a great question. The answer can be a little more complicated, but I'll give you a first simple answer first and a little complicated answer. First simple answer is that what I meant by autoimmune disease with the COVID is that most autoimmune diseases happen after some kind of infection. Basically, the immune system is confused. It's possible that our body tissue, maybe the nervous system, may look very similar to that of COVID virus. So when virus fight against the virus, immune system fight against virus, they may develop, after virus is gone, our body may recognize our own body tissue as a virus and then inflamed it. It's a random chance. Actually, there's a research, it's a pretty interesting research that came from Hopkins team early in the pandemic, Dr. Anthony Rosen. And that actually kind of similar results has been reproduced by others, is that during the severe COVID infection, somehow the thing about COVID virus that's a little interesting than unique than other viruses, that this virus tends to host a lot of autoimmunity, meaning this virus itself seems like it can cause different kinds of autoimmune reactions. So that's been kind of suggested in some studies.
Sure. So moving forward with a question from Henry, with what you're saying, Dr. Chung, so what are the similarities and differences than with other chronic viral infections, like if you have Lyme's disease? Do they show themselves almost similar? Are you able to see the differences?
Good question. Well, similar, but caveat is that chronic Lyme syndrome is not just one thing. And we know that actually autonomic dysfunction or POTS is actually not as common as you think as a part of chronic Lyme disease, but some people develop POTS. We know that we work at the Lyme Center, probably about 5 to 10%, and they do look very similar to post-COVID syndrome.
Particularly in those patients presenting with chronic fatigue syndrome, we know that many of them have an infection as a preceding event. So they're kind of considered post-infectious fatiguing illnesses. And they're very similar in that presentation in terms of the extreme exhaustion that declines functionality, to its disrupted sleep, orthostatic intolerance, meaning that they can't tolerate being standing, and cognitive dysfunction. So that particular cluster of symptoms is chronic fatigue syndrome, and we can certainly see that after infectious.
So for anyone out there, if they have any of those symptoms that you just described, so where do they start? Do they go back to their internist, their general practitioner? Where do they go with this? And if they've had COVID, now have these symptoms, or have these symptoms, haven't had COVID, or maybe they've been exposed at some point, maybe it was a year ago they had COVID, right? So what would you all recommend for the average person out there who's listening? Where do they start?
I think that they need to start with their primary care physician. A lot of the symptoms can be also caused by other things that we understand really well and that we're very able to diagnose. So a lot of the initial workup can be done with your primary care physician, checking for things like vitamin insufficiencies, different hormones, like routine tests like your thyroid. All of those things can present with similar symptoms. So it's important to make sure that those are not contributing, or if they're contributing, they can be treated, right? So I think that the start is always with the primary care physician.
So it sounds like what all of you are saying is that, and even if you did not have a pre-existing condition and you did get COVID and you started getting these types of symptoms, definitely go back to your internist or primary care physician and don't just chalk it up to, well, I've never had this before. And because as you all are saying, you're learning as we go here that we're not sure exactly where all this is coming from. So with that, our next question from Allison, she would like to know, has there been any progress in solving the loss of taste and smell?
Parker likes to take this one.
Oh, I don't know. I think there are still a lot of theories out there regarding exactly, why individuals have that initial loss of sense of smell and taste, and why perhaps it might persist or return at a later time. We've been very fortunate. We have a colleague in otolaryngology who has had a longstanding interest in olfactory dysfunction or abnormal smell that preceded COVID. And so very early on, he partnered with our program and actually implemented, as we do very often in our program, in the absence of data really driving treatment options specifically for the post-COVID population or long COVID population, we rely on our evidence-based approaches to treating similar symptoms or conditions, that predated COVID. So, for example, our colleague, Dr. Rowan in otolaryngology, had already developed a very extensive and well-thought smell rehabilitation program that we were able to then provide to our patients step-by-step instructions on how they could start doing smell rehabilitation, which, as a pulmonologist, that was news to me when this all started. But, Dr. Rowan was well-versed in this. And so I think just an example of a way that we were able to rely on expertise across departments to really start to understand that.
Yep. Thank you. Our next question is from Kim, and she'd like to know, is there concern about potential long-term neurological symptoms?
Well, if I might chip in, I think that's the whole dysautonomia thing is actually in the whole, probably one of the most kind of maybe a little scary kind of a neurological consequence, because it's assuming that this is autoimmune inflammatory neuropathy in the autonomic nervous system. That's it's not something that goes away, right? Just spontaneously without any treatment. So that's probably going to be something that's most, concerning side effects. Of course, much rarer, as expected, something like Guillain-Barré syndrome, which is also autoimmune reaction after any kind of viruses in the nervous system that can cause some kind of nerve damage. Not permanent. It's just one-time thing. But there are a few other very rare conditions where they can have permanent nerve and muscle disease. It's extremely rare, but a little more common in maybe dysautonomia.
Thank you. Yes, I would imagine as, again, just time-wise with data, right? This is all kind of fresh and new, and maybe as time goes on here, we'll have a little bit more clarity.
The short answer is we don't know.
Yeah.
Well,
Well,
sorry,
enough though. I'm sorry, Dr. Parker, please go ahead.
No, I'm sorry. I know, I was just going to say it's important to keep in mind that, again, when we're thinking about long-term complications, as hard as it is to sort of comprehend because it feels like we've been doing this forever now. But when we think about long-term complications, we're really just starting to scratch the surface in terms of, you know, thinking about things that symptoms that might be there months or years down the road. So, you know, I think the science is moving, but we, to some degree, need some time to understand things like trajectory. We know certainly more now than we did a year or a year and a half ago.
Right, exactly. Thank you. Our next question from Amy, if you have POTS, should you continue to be boosted or will it perpetuate the autoimmune response?
In terms of the vaccine, you mean?
Yes.
So I would say yes. I guess, I mean, let's say, you know, again, this is a little more theoretical, like with autoimmune. There's no biomarker who actually has autoimmune parts from COVID or not. But theoretically, let's assume that there's some, and as expected, I mean, it's not surprising that any virus can cause some kind of autoimmune reaction to either autonomic nervous system or peripheral nervous system. And something like Guillain-Barré syndrome is really well known to happen after any virus or even vaccination. And people will say, yeah, then vaccine can cause POTS or Guillain-Barré syndrome. And technically, short answer is yes. And it's actually not surprising. For the same reason, any flu vaccine can cause Guillain-Barré syndrome as well. It's really well known. But you know, why do we get flu vaccine or post-vaccination? Because this is actually the same thing with the first question. Because you're less likely to develop Guillain-Barré syndrome or POTS as an autoimmune reaction after vaccine versus, you know, after getting actual infection. And there's a lot of theoretical reasons why you're more likely to develop such autoimmune nervous disease when you actually get, you know, actual virus versus vaccination. And we are still kind of in the COVID pandemic. There's still a chance we can get the COVID infection out there, and you can always develop it. Whereas still vaccination can, so in that perspective, vaccination is still preventive. And that's why I said in the first question, what to do to prevent the post-COVID, if it's for POTS, still the vaccination is the answer.
Great, great.
Yeah, I would just emphasize that, you know, I think we've seen now, you know, so many of the population has been vaccinated. I think side effects and adverse reactions to the vaccines are exceedingly rare. So we do know that we have safe and effective vaccines available. When I think broadly about autoimmune disease, because we have a lot of patients who we see who had pre-existing autoimmune diseases, as well as newly diagnosed autoimmune diseases. And I think a really key piece of information there is when we treat autoimmune conditions, by definition, we suppress the immune system, right? And so our patients with autoimmune disease are often on very, immunosuppressive medications. And for that reason, all the more reason that we would want to make sure that they are not only vaccinated, but also boosted. And then we have other tools now. I mean, amazingly so. It's just incredible how fast science has moved. I know as hard as it is to believe, but we have other tools, you know, things like Evusheld that, you know, we can use to even help bridge that immunity to some degree for our patients who don't mount enough of a response to vaccination or prior infection. So it is very rare that I would recommend against vaccination, really only in the setting of a known serious adverse reaction to the vaccine.
Great.
Just to add a little bit, I'm sorry.
No, please, go ahead.
Having autoimmune disease doesn't necessarily also actually mean that they have to be on immunosuppression either. So, you know, I don't think we have to think that you have to be on some kind of crazy immunosuppressant, even if it's autoimmune disease. It doesn't really mean that. And also those kind of small number of patients, I've seen patients who develop severe cases of some POTS or dysautonomia, even after vaccine. Still, there's no way you can prove that's caused by vaccine. It could have been some subclinical infection from COVID before. There's no way to know that. I'm not dismissing, nobody here is dismissing their symptoms. We're just not kind of reacting to, but for the same reason that we talked about, we still recommend vaccination because overall, I think it's still safer that way.
Right, thank you. Our next question is from Leanne. What treatments are currently effective and approved by the FDA for long COVID? If any.
None.
Mhm.
There
No.
are none.
Yeah, but that is a really, really important question. Throughout the pandemic, we have encountered, unfortunately, sources of misinformation. And so we very frequently, have patients ask us about certain medications, ivermectin, hydroxychloroquine, even Paxlovid specifically for long COVID, so well after that acute phase of illness. And none of these medications are FDA approved or even have, in the United States, an emergency use authorization, or have, really any grounding for use in long COVID at this point. So, but that is a really, really great question. I think a really important message to get across that, when you're considering, potential therapies, whether it be pharmaceutical or otherwise, that you're really doing it under the guidance of a medical professional.
Yeah, I just wanted to highlight long COVID patients are a particularly vulnerable population. They have all the symptoms that are quite debilitating and they don't have a particular treatment. So there are predatory advertisement initiatives, and not naming any names, but it's important to be aware that the science is not there to solidify the use of certain medications, and to know that there are vulnerable population and there's risk for that type of treatment.
So with that, I'm sorry, Dr. Chung, go ahead. Please.
Add a little bit just to not to discourage the patients too much. That FDA approval doesn't necessarily mean that this is the end of the thing. Well, like seeing Dr. Parker Azola or rehab therapists, I think this is very effective and helpful. Not having the FDA approved drug doesn't mean that there's no help. You don't have to get an FDA approval to see Dr. Azola, Dr. Parker. It helps, okay?
Yeah.
But would you also say with that though, speaking about the long COVID, so once you've tested for COVID, two things, how long does it take afterwards for that you would consider, gee, you're in the long COVID stage? It's question number one. And number two, once you're diagnosed with you're positive with COVID, what about the drugs that are the IV and the other drug that are recommended to take? Will they help to prevent long COVID or not?
Yeah, so I think theoretically, one of the risk factors that have been identified is that increased viral load. So receiving treatment to decrease the viral load potentially could help decrease long COVID. It's a big stretch. We don't have that direct connection, but I think that definitely there's a potential for help in that. And then the other thing was the definition that Dr. Parker had already mentioned. So symptoms that are lasting for more than 2 months within 3 months of infection. That's the definition that we use, the WHO case definition.
Okay, so how do you, question from Debbie, what she'd like to know, so how can you get into the long COVID program?
That's a great question. And so again, you always want to start with your primary care provider. And so we do ask that our patients contact their primary care provider, and then we have our website that I'm happy to share, perhaps through an email distribution that our patients can access. We have our referral information, links, and contact information there. But very, very important to start with, your primary care provider. They know you better than anyone, and also can do some of that initial evaluation. Sometimes there are very often there are alternative explanations for the symptoms that some of our patients are experiencing. And so this is bread and butter for our primary care colleagues, and they recognize when, you know, there is something going on that requires additional referral, you know, and are equipped to make that next step in a patient's care.
Would they then refer them to you if you were here in Baltimore?
Yeah. So we get most of our referrals at this point from our primary care colleagues, you know, in this area. And so, you know, we have as you can imagine, there are a number of post-COVID programs throughout the world at this point, but not nearly enough to see every patient, you know, who has had COVID, for example. And so we do try to do a careful review to make sure that the patients who are being referred to us, we're able to meet their needs and we have the right services, you know, to offer them to do an additional evaluation or offer management beyond, you know, what they're already experiencing. But, you know, that access with relatively few post-COVID clinics, you know, given the number of individuals who have been infected at this point, really, you know, requires that we, you know, have our primary care colleagues, as they so often are, and do an amazing job on those front lines. And the other thing I would say is, you know, I think the WHO definition very carefully considered that time frame in terms of understanding that many people will improve substantially in those initial few weeks to months. And so really, you know, the majority of people, the vast majority of people who have COVID will continue to improve back to their baseline. It is more the exception to have persistent symptoms, and that's really important because we don't want individuals thinking that they are, you know, doomed to long COVID if they get an acute COVID infection.
Great. I'm glad you mentioned that because that's actually one of the questions, and very important and encouraging for anyone who's struggling with this. So our next question from Leanne again is, what is the long-term goal for Johns Hopkins research on long COVID? And each person with long COVID has different symptoms and each patient presents differently. So how is this being addressed within the research that's being done?
That's an outstanding question. So this is not you know, a research realm that any one group or one university is going to be able to tackle on its own. And Hopkins, our program included, has participated in research that crosses not only departments within our own School of Medicine, but we have also collaborated with individuals from other institutions as well. And that's what it's going to take. It's going to take team science, you know, just like it did for developing vaccines and interventions for management of acute COVID. And I mean, that's what's amazing. You know, one of the amazing stories of this pandemic is, you know, groups pulling together amazing team science that crosses, you know, international lines in terms of collaboration to really help move the needle forward. So things like the Recover Network and similar programs internationally to help answer some of these complex questions.
Great, it's wonderful. So another question we have is from Fritz, and he would like to know, can you estimate the number of Americans with long COVID?
9.4 million, if you
Wow.
count as of yesterday, the 12th. So there's actually a dashboard that looks at past estimates. They use their Hopkins numbers to derive 10% of those that are positive, you know, will present with lingering symptoms, and that's the number right now at 10% estimate.
Okay, thank you. You knew that right off the top of your head. I like that. Good for you. Our next question is from Tolu, and the question is a persistent low-grade fever a part of long COVID?
That's a great question. I know Dr. Azzola wants to answer this as well. So I'll say a little bit, and then I can you know, we know each other so well at this point. I can feel her jumping in. So, you know, I would say fever is generally a bit of a red flag symptom from my perspective.
Mhm.
If you have fever lasting, more than a few weeks after initial COVID illness, I would want to evaluate for other potential causes of fever. And so, we think about, longstanding sort of workup that we would do to rule out other infectious causes, things like malignancy that can contribute to fever, other inflammatory conditions. All of these things are rare. But we wouldn't want to miss them if they were there. So we would certainly think about each of those things. And we do have a few patients who do continue to have, relatively low grade fevers. And it sort of depends on how you define that. And I would joke, if you talk to a medicine doctor and you talk to a surgeon in the same hospital, you'll get different definitions of a fever. But I think, a fever that's persisting for many weeks and certainly months after an initial COVID illness would make me look into other possibilities as well.
Mhm.
And once those possibilities have been exhausted, which we have done with several of our patients, we have identified patients that continue to have fevers. Some patients with autonomic dysfunction will have temperature regulation issues, but not particularly fever, but they will feel hot when it's cold and cold when it's hot. But some of the people that have the exaggerated allergic response that I was mentioning will have episodes of elevation in temperature. And by treating that exaggerated allergic response,
Mhm.
some of those fever symptoms can subside. It's a case-by-case thing. But
I see. Yeah. Well, if you're talking to menopausal women, you just sum them up right there.
oh, that's another
Yeah.
thing. Yeah. Many of them, if they're between ages 46 to 50, some we've certainly screened for kind of premenopause, and a lot of them, with hormone repletion, their symptoms improve. I think there's several nuances to identify, but definitely something that we keep in our mind.
Yes,
With that
I would imagine. Yeah, that's
demographic.
tough. So we just have about 2 minutes left. So quickly, this is a question from Holly. What other departments or divisions within Johns Hopkins are part of the PAC clinic, and what research is being conducted in those areas as related to COVID-19 and long COVID?
Oh my gosh, I don't think I can answer that in the amount of time we have, but what I will say that within physical medicine and rehabilitation, we have numerous disciplines as well. So we have physiatrists, neuropsychologists, physical therapists, occupational therapists, speech language pathologists. We also have a psychiatry liaison within our program. And then we have partnered very closely with, for example, I mentioned Dr. Rowan in the Department of Otolaryngology, who has a specific interest in this area. We have colleagues within cardiology, who have an interest and who we work closely with. In terms of research, I think one of the partnerships that I would highlight is our partnership with the Johns Hopkins Memory and Alzheimer's Treatment Center, Dr. Esther O, who is very interested in understanding cognitive outcomes for this patient population. So we have taken advantage of, for lack of a better word, expertise, and subspecialty expertise and passion and interest and knowledge throughout Johns Hopkins, to help answer some of these questions.
Great.
Yeah, I wanted to add on Nisha Gilotra, who's from cardiology, who's also partner up for those patients presenting with cardiac complications after COVID.
Wonderful.
There's too many to name. Yeah.
Listen, it's wonderful, and I'm sorry to have to cut this short, but it looks like we're getting close to the 8 o'clock hour, and I would like to thank Drs. Azola, Chong, and Parker for speaking with us this evening. Thank you very much. The doctors have graciously agreed to respond to any of the unanswered questions that were asked this evening, and we will also include the clinic email, the website in the email as well, which you'll receive in a couple of weeks with the answers of the questions and that email. So in the coming days, a video of tonight's live stream will be available on A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, under videos on demand. And if you'd enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for information about A Woman's Journey. In particular, our upcoming program on Saturday, October 29th of this year at the Baltimore Marriott Waterfront Hotel in Harbor East. Join us in person or virtually, where you can listen to our keynote speaker discussing her brave and long journey with COVID-19. Enjoy 3 presentations by Johns Hopkins medicine physicians who will focus on memory, symptoms you shouldn't ignore, and vitamins and supplements. The program and brunch begin at 9:30 a.m. and it'll end at 11:45 a.m. After that, you'll have the opportunity to speak with Johns Hopkins physicians who will address 13 health issues from COVID, vaccines to plant-based diets, cancer, sleep, and other topics. As always, you can visit our website to register for this special program. And for more information about upcoming webinars, our Insights That Matter podcast series, and sign up for our monthly email. Thank you, everyone, and good night and stay well.